So welcome to this 20-minute symposium on the Episealer mini-metal individualized implant for focal chondral and osteochondral defects in the knee. I'm Tim Spalding from Coventry in UK, and I'm joined by orthopedic surgeons Johannes Holz from Hamburg, Germany, and Martin Lind from our house in Denmark. The aim is to report on the latest results from a specific cohort of patients with minimum follow-up of 2 years, and then to define the place of this implant in our treatment options for articular surface damage in the knee. I will present the results that have recently been published, and then Dr. Holz will present on the role in his practice. And finally, Dr. Lind will present his experience and outline where he sees the place for this implant. So let me present the results and indications for this implant. The implant is a metal resurfacing implant targeted at the treatment gap between the biological repair at one end and arthroplasty at the other end. Now we've put 50 in the middle here, but essentially the age range is from 35 up to 65, where we're more likely to see arthritic bone-on-bone change. And it gives us this treatment option for that gap for the higher demand patients. And essentially, we've now got predictable implants, and we need to define that indication, buying time before knee replacement. The Episealer is more than just an implant, it's a mini implant system. And you can see here on the right, the actual specific implant from highly polished cobalt chromium with HA on top of the titanium coating for the bony ingrowth. So that's the implant. But on the left-hand side here, you can see that we have this damage marking report. We send the MRI scans to Episurf, who then can map out exactly where the implant will go and give us this damage marking to make sure it is suitable for that repair. Then the actual system is the guide, a 3D printed guide, which allows accurate positioning of the drills to allow the best positioning for the implant, recessed 0.5 millimeter below the joint surface. The technique information is available on the website, but this presentation is really going to focus on the results of this whole system. The result when you do it then is the guide from the damage marking, which sits exactly where it says, you can see on the second image, and then once drilled and recessed and implanted, the implant then looks on the right-hand side, perfectly recessed and covering the damaged area of articular surface. The rehabilitation afterwards is 2 weeks touch weight bearing and 2 weeks progressive weight bearing to full weight at around 4 weeks, with free range of movement allowed and building up strength from about 8 weeks. We generally recommend avoiding impact activities, so we know some patients go on and do quite significant activities on this. The multi-center study we've just published, and it's just been published in Kester. But essentially, this is a prospective study, 80 patients with 24 months outcome, where we've collected the specific outcome scores. And this is for focal chondral and osteochondral defects, grade 3 or 4, where biological repair has not been indicated. And it's a single lesion on the femoral condyle with intact tibia cartilage, and those are important entry criteria. The data collection has been the demographics detail and surgical data, collecting outcome scores at 3, 6, 12, and 24 months. And we've collected the KOOS score and the visual analog score. And you can see on the right here, the surgeons who have been involved in this study. For the specific cohort, we have 75 out of the 80. 2 have been revised, and therefore we don't have the complete data set on those. 1 has declined to be followed, and another 2 did not complete all the specific outcome scores, so we can't map those. 44 were females, that's 59% female, mean age 48, and the BMI of 28. 65% had previous treatment, and you can see that listed here, with most of them being microfracture, but there was included mosaicplasty, ACI, TrueFit, and then just arthroscopic debridement. The specific locations are on the right-hand side. Here were 65 on the condyles and 10 on the trochlear, either being the solo or the twin. Now the outcome for the whole group is here. This is the KOOS score on the left and the visual analog score on the right. So you can see on the KOOS score, we've got 4 time points from pre-op, 3 months, 12 months, and 24 months. And you see improvement in the pain scores, the symptoms, the ADL scores, and the sport scores. This is not a procedure meant for high-level sport. And then for the quality of life, also improving over this time point out to the 24-month period. And this is mirrored in the visual analog score for pain, showing the improvement over time from pre-op. Do note the score goes from 20 here to 70 on the left-hand side. When we look at the implant type, then there's no significant difference when we looked at KOOS-4 and the visual analog score. So the bigger numbers in further studies will show if there is any difference, but essentially on the numbers we have here, there is no difference between the solo implant, the twin implant, or the trochlear implant, or the outcome scores on KOOS-4 or on the visual analog score, improvement over time. If we look at the outcome, depending on whether there was previous cartilage treatment or not, then there is no significant difference here. Blue is the primary cases with no previous surgery, and red is the prior cartilage procedures. Although there may be looking like there is a difference, this is not significant difference on the KOOS-4 score. For the results in terms of the adverse events, we have two revisions. The case 1 was revised to a unicompartmental knee replacement, still having pain at 15 months. And the second case had previous OATS procedure, who was never really happy with the result from the OATS with subchondral cysts, and a thicker implant was used. And that's the benefit of the technique here, that you can have a thicker metal part of the implant designed. No improvement, and that patient was revised at 90 months using a bone graft with a chondroguide membrane on top. We've had one infection who was revised beyond the 2-year point, and 2 arthroscopies for debridement of scar tissue and mechanical clicking, and then 1 DVT in this series. So putting this together, partial knee resurfacing is not new, but the results from the previous implants that have been published are variable. And so this newer implant has been focused on here in this presentation. What I've done really, this is a select cohort analysis of 75 implants at 2 years, with the 5 that were excluded. But essentially, this gives us a very low failure rate, 2.5% in this group. So we've seen good clinical improvement as shown by the KOOS score and the visual analog score. We've shown that this individualized design is accurate and allows us accurate positioning of the implant exactly where we want it, covering the defect, and that's all the benefit of this damage marking report. The depth and the location is easy to achieve because of this instrumentation. And that is I think for me, one of the key features of this, and we're going to hear that in the next talks. The future focus for this work is to really try and detail the best indications for this implant and see exactly where it sits in our options for treatment. So I thank you for your attention with this. I acknowledge the surgeons who've been involved in this data collection. And I would now like to hand over to Johannes Holz, who's going to detail where this sits in his treatment options. Thank you.
Dear ladies and gentlemen, I was asked to point out the role of a novel patient-specific mini implant for cochlear cartilage lesions in my practice. Cartilage restoration goals are well defined, and finally we aim to prevent or at least delay total knee replacement. Treatment algorithm depends on defect size and location. Small defects are the domain of biological repair, whereas mid-size or large lesions are limited to biological repair or are not as promising in older patients. Here, unloading treatment like a high tibial osteotomy is suitable, or partial knee replacement might be considered. A treatment option, especially for focal cartilage full thickness lesions, are mini metal implants, especially in patients where biological repair has failed or is not promising of age. So these are patients where no indication for partial or total knee replacement is indicated. As treatment options, the introduction of the HemiCap system is a surface reaming matching inlay implant with a screw fixation, was introduced in 2003, and I was using it regularly from 2006. But in our own treatment group, a revision rate of 20% was evident, And in the results of the international register data, the cumulative percentage revision of partial resurfacing undertaken for osteoarthritis was up to 50% at 12 years. Possible reasons for failure are the poor congruency with surrounding native cartilage, that the implant might be implanted too proud, and the insufficient remaining meniscus function, or just because the implant is not individualized enough. Here you see the example of a 50-year-old and a follow-up of 10 years. So, but if those implants work, those mini implants, they work, and even that time period of 10 years. With an individualized patient-specific implant, the Episealer, we achieve the perfect copy of the native surface and could possibly prevent the problems we have seen and experienced with the conventional implants. The depth of the implant reaches always a safe zone of 0.4 millimeters by stepwise deepening by 0.2 millimeters. We perform a perfect pre-opening planning through a 3D MRI imaging, and we minimize technical areas by using personalized instruments and a personalized implant. My personal experience includes 45 Episealers surgeries in the last 5 years. 78% of the patients had prior surgery without success, and we documented 2 revisions over the 5 years. We have followed up patients, including 23 patients in the CPL multicenter study, and the 2-year results were already demonstrated by Tim. The first 5 patients who reached 5 years follow-up decreased their pain to VIS of 1.62. In the average course, they were able to progress to 81 out of 100, having started at 50, and in the subscales for pain, activities of daily life, sport, quality of life, those patients scored best at 5 years. Here you see the case report of a 43-year-old female woman with a history of pain and a history of pre-surgery with a disease progression in the lateral femoral condyle in 2015, evident in the MRI. You couldn't see any kind of joint space narrowing in the weight-bearing X-rays, but in the damage marking, you can see, you could see the full thickness lesion on the lateral condyle. And the MRI sequences based on the damage marking, you see the full thickness cartilage as red and covered with a 17 millimeter diameter Episealer implants. And finally, you have a final implant and instrumental design, which will lead to the surgery. And here are the post-op weight-bearing X-rays showing the implantation. The patient is very well off after 5 years, no pain, and 99 in course and 98 at the health scale, and no pain is evident. Over the last 20 years, we have established a selective arthroplasty algorithm preserving as much of the native joint as possible and replacing only the damaged areas of the knee. As you can see, out of 750 arthroplasties, only 200 patients received a total knee. In 55% of the cases, medial or lateral uni was used, and in less than 10% of the cases, each patellofemoral joint, bicompartmental or Episealer in 7% of the implants. Over all procedures, our patients significantly improved over a period of 2 years, and the results of our group of the small knee arthroplasty fit well into this algorithm. In summary, partial knee resurfacing is a growing segment with a variable outcome with up to 50% revision rate. Episealer is an excellent option for isolated chondral or osteochondral defects. It has a low failure rate, 2.5 at 2 years in the CPL group and 4% at 5 years in my follow-up, and it has good clinical improvement for those patients. Individualized design is accurate, depth and location is perfectly achieved, surgical technique and instrumentation is excellent, but there is a need for a correct indication, and the patient selection is the key to success. Thank you very much.
Okay, thank you, Tim, for the introduction. And I'm Martin Lind from Aarhus University Hospital, Denmark, and I'm going to talk about my indication for Episealer, or the individualized mini metal implants in the knee. And the clinical problem we're facing is that we have patients in the so-called gap age, typically between 35 and 60 years old, that has focal cartilage lesions and these patients are often considered too young and with too limited cartilage pathology for arthroplasty, but they are too old for biological cartilage repair. And this is illustrated here, that we have the patients that are indicated for biological repair and the patients that are for arthroplasty, and between those we have the gap group. And these patients often have symptoms that are as severe as full osteoarthritic patients, and they have a demand for an active lifestyle, short rehabilitation times, and predictable clinical outcome when treated. So my indications are that a patient that has a symptomatic focal chondral or osteochondral lesion, either in the femoral condyles or the trochlear, or it can also be patients that have failed biological cartilage treatment. And they should sort of be in the age group that we just talked about, between 35 and 60 years, where they are not suitable for further biological treatment or arthroplasty. To illustrate my indication, I have two cases. And the first case is a 53-year-old woman. She has had 2 years of symptoms from her left knee. There's no trauma in the history. And she's suffering from activity-induced pain and knee swelling. And her imaging, here MRI, demonstrated that she has a lesion on the medial femoral condyle. It's a clearly degenerative lesion, grade 3B, with exposed bone. And she also has some minor trochlear and lateral lesion as shown on the 3D reconstruction. The surgical planning for the Episealer implant is seen here, where it was found that a 2 by 20 millimeter twin implant was needed to give an optimal coverage of the lesion. And that leads to the surgery, where on the left you see the arthroscopic imaging of the lesion, which is a clearly degenerative lesion with exposed bone. The intraoperative images, we have the dummy implant showing how the implant would seat, and to the right, the final implant in place. And the post-op x-rays below showing nice positioning of the implant. The follow-up for this patient and outcome was at 1 year, she was completely pain-free and highly satisfied, and her KOOS profile demonstrated clinical relevant improvement in all subscales. And she actually returned 3 years later with similar symptoms from the contralateral knee and requesting the same treatment. And she still had optimal outcome of the first operated knee. My second case is a 51-year-old male. He had 2 years of symptoms from the left knee, and he had 20 years prior a microfracture that failed after a couple of years. And he was then subsequently operated with an osteochondral transplant and OS procedure. And from that, he had good outcome for more than 10 years, but now he has pain with activity and mechanical symptoms. His imaging is seen here, where we can see subchondral pathology with bone edema, and there's in the cartilage still remaining cartilage, but there's fissuring and edema. But it's clearly that there's this subchondral pathology. Also, he had some trochlear cartilage wear. And as the surgical planning imaging is seen here, again, a 2 by 20 millimeter twin implant was needed to cover the defect. And we can see on the 3D reconstruction that there was some trochlear degenerative changes as well, but we moved on with an isolated implant. And here we can see again the surgical images, the arthroscopic image. We can see that there was still some cartilage from the osteochondral plugs, but there was fissuring and degenerative changes around it. And we have the guiding system at surgery covering the implant, making ready for reaming, and here the final implant in place. And also nice post-operative x-rays showing the implant in place. His outcome is seen here. Also, he had clearly reduced pain and was able to return to low impact sports, and he was very satisfied. And also his KOOS profile demonstrated the clinical relevant outcome and improvement in all of the KOOS subscales. So these were my indications and illustrated by these two cases. Thank you.
Thank you, Martin and Johannes, for your excellent presentations. I would like to leave everyone with this slide listing the indications for focal resurfacing in 2020. and draw your attention to the website episurf.com, the videos on technique and the full detail behind this implant and any further information.